Hey everybody, welcome back to another online lecture for Nursing 234 from Mount San Jacinto College's Associate's Degree Nursing Program. As always, I'm Professor Garcia. Keep it down guys. Trying to get this thing done, and I just want to make sure that you guys are able to review this before the test coming up. Today we're talking about pain and the way to manage it, the way to assess it, and recognize early signs, to stay ahead of it, and to do the best for our patients, of course. So here we have Nick Fury. Pain is just fear leaving the body. So here we go, guys. So the objectives, should you choose to accept it, is to differentiate between the types of pain and discuss the drug therapies for mild, moderate, and severe pain. There's a few different types of pain that we're going to discuss. Of course, there's acute, chronic, and of course, cancer pain. So what is it? Pain is basically what people say it is. It's been Iggy tried to define it as an unpleasant sensory and emotional experience associated with actual or potential tissue damage. But again, ultimately it comes down to what the patient says it is, regardless of signs or symptoms of distress, or your own pain tolerance, or what you think person should be able to tolerate. It all comes down to the subjective data and what that individual says it is, and what they can tolerate. So basically, self-reporting is always the most reliable indicator of pain. So what happens if pain is not relieved? I mean, obviously, when we talk about our nursing diagnoses and when we're formulating these plans of care, all of you guys start out putting as a nursing diagnosis, as a priority nursing diagnosis, pain, acute pain or otherwise, and I always get on your guys' cases about it, but it's the squeaky wheel, and it's usually the most prominent thing that we have to deal with on the medical surgical floor, or other various aspects or environments of nursing. Pain seems to be the most prevalent, so it usually gets the how would you say, the blunt of our care, or rather the majority of our care. But there's a lot of things that can happen if the pain isn't relieved. I'm not trying to underappreciate pain. I'm just saying that typically pain doesn't kill us. So when I have you guys formulate those nursing diagnoses as a priority, I usually have you guys approach it as in a way that you would say, okay, I have 12 hours with this individual. What will kill that individual, or what will really send them off into the deep end? And you want to obviously devise a plan that will prevent that. Now, pain, though, can have a number of physiological, quality of life, and financial impacts. So a few of those physiological impacts are prolonged stress response, increased heart rate, blood pressure, and O2 demand, decrease in GI motility. It can cause immobility. It can decrease immune response, which we don't talk about very often, but it can delay healing and decrease immune response because it is a type of stress on the body. It does require a metabolic demand. It may lead to chronic pain if not addressed and managed properly. It can have a profound effect on quality of life. It can interfere with activities of daily living. Just think about your patient that you get on the med-surg floor, and they looked kind of unkempt and kind of neglected, not shaving, not showering well. I mean, you just think about this individual has this chronic pain or lives with this pain, and it's just the last thing they want to do is get groomed up and looking real pretty. It's all about just minimal for them. A lot of times they don't even eat. Causes anxiety, depression, fear, hopelessness, anger, and sleeplessness. So not only does it cause these psychosocial kind of effect on people, but it also can cause sleeplessness, obviously, which can exacerbate a number of things. And obviously the body just doesn't function optimally when you don't have enough sleep or nutrition. It can impair family, work, and social relationships. So if you're a chronic pain patient, and you're in a type of work that requires physical exertion, obviously that's not going to last very long. Or even if you can't do the simple things like repetitive bending down and standing up for whatever, whether that's you're the in-processing person for a factory or a warehouse, and you have to check everything in and out. Obviously that would impair you even from doing that. So this can have a vast impact on family. Like if you think about that, where you're no longer bringing home the bacon, and maybe wife or husband or whoever was the primary breadwinner now has to relinquish that to the partner, and now that person feels stressed, and that may affect relationships. The financial impact is immediate. Obviously, it costs Americans billions annually, but it's that if you can't work, you don't have that money, and you can only collect unemployment for so long. So again, it just leads to lost income and productivity. Pain is usually categorized into two categories: acute or chronic. Acute has short duration, usually has well-defined cause. Decreased with healing, is usually reversible. Initially serves biological purpose in the sense that, I was on the basketball court and I twisted my ankle, sustained some sort of inversion or eversion injury, trying to block some shot from going in, telling them to stay out of my kitchen or what have you. And I come down, land on my ankle, twist it, immediate swelling and pain. Obviously, it serves a biological purpose in the sense that, while it's going through healing to allow, obviously to let me know right away there's been some sort of injury, to not, to get off of it, to elevate it, to, take a look at it, obviously. When prolonged, it serves no useful purpose. Pain doesn't. It ranges from mild to severe intensity, may be accompanied by anxiety and restlessness. When unrelieved, can increase morbidity, mortality, and prolonged hospital stay. For chronic, usually lasts longer than 3 months, may or may not have well-defined cause. It usually begins gradually and persists, and it serves no useful purpose. It ranges from mild to severe intensity, and it's often accompanied by multiple quality of life and functional adverse effects, including depression, fatigue, and financial burden, and increased dependence on family, friends, and healthcare system. It's kind of what we were talking about in the last slide, where, at first you can't work, vast effect on your financial situation. It may strain relationships. It may cause new roles in relationships where, it might cause your kids to be more involved in, doing things around the house that were roles that you typically took care of. And that may, again, just place some strain on those relationships. It can impact the quality of life of family members and friends. And just just think about, someone with chronic back pain bending over to tie their shoes or getting out of bed to jump in the shower to go fix themselves a meal or what have you. So, pain is definitely something that we have to consider always. Chronic pain, also called persistent pain, continued here. So chronic cancer pain. Many report pain at the time of diagnosis, which increases in advanced stages. This is usually due to tumor growth and nerve compression, invasion of tissue, or mets. Typically, when a cancer patient has pain, it's because the tumor or the mass has grown to a degree where it's impeded some sort of function of any some sort of organ, or it's pressing against something, or tissues causing an uncomfortability. Usually it's a latent sign, pain or masses that are palpable. It's most often well managed with around-the-clock opioids. Cancer treatments can also cause acute pain. People like radiation therapies, GI abdominal pain with certain chemotherapies, skin issues again with radiation therapies. People with cancer usually have pain in 2 or more areas. The chronic non-cancer pain, the global health problem affecting most often older patients 65 years or older. Again, just think about this physiologically as our bodies begin to break down a little bit as we age. Muscle mass decreases, elasticity in the skin, less synovial fluid in lubrication in our joints, degenerative joint issues or gradual degeneration in our bone structure. So, bending over and, just tying our shoes can become a big ordeal. Most common areas of chronic pain are neck, shoulders, back following injury, and of course joints. Chronic conditions that can elicit chronic pain can be from diabetes, such as neuropathy in our feet, rheumatoid arthritis, Crohn's disease, so stomach issues, interstitial cystitis, and fibromyalgia, which is a generalized body pain. So we categorize pain by the underlying mechanism. Nociceptive pain is a term used to describe how pain becomes a conscious experience. I don't want to get too much into this. Essentially it's just synapses from the brain that, we touch the burning stove or the hot pan. First of all, it sends an impulse to the brain. The brain sends one back to us that says, remove hand, pain. So, long story short, they're just, impulses and messages sent from the point of origin to the brain and then back down saying, remove yourself from the noxious stimuli. So it serves that purpose, first and foremost. It involves physiological systems of the central nervous system that translate noxious stimuli as pain, uses methods of transduction, transmission, perception, and modulation. Neuropathic pain, term used to refer to pain that is believed to be sustained by a set of mechanisms that is driven by damage to or dysfunction of parasympathetic and or CNS system. So the comprehensive pain assessment. So how do you guys assess pain in the clinical, med-surg, acute clinic, acute care environment? Well, it comes down to OPQRST, as I always tell you when you're doing your head-to-toe assessments. OPQRST, regardless of its chronic or new onset, always OPQRST, which stands for onset. When did it begin? Provocation, what makes it better, what makes it worse? Quality, is it sharp, is it throbbing, is it pressure, is it burning? Radiate, does it move anywhere? Does it, your chest pain, does it stay right there in the mid-sternal region, or does it go around to your back? Does it go to the left side, neck, jaw, shoulder? The severity, obviously 0 to 10. 10 is the worst pain you can imagine, or you can say 10 would make you scream and cry right now, and 0 is no pain at all. How would you rate this? And time. Remember, subjective description of the experience and measurement of pain intensity are more reliable and accurate than observable qualities of pain. Again, basically this says whatever the subject tells you the pain is what it is. It's more accurate than you saying, you know what, but you're not grimacing and you're not writhing around in pain and you're not kicking your legs and you're not crying, so it can't be a 10. But if you give them that pain scale, there obviously is something that could make an individual scream and cry. So I usually try to paint that picture. So think about something that would make you scream and cry, or imagine a pain that would make you scream and cry. That's a 10. 0 is nothing at all. What are you in between that? There's types of pain scales for the person that is nonverbal. But first of all, the verbal, again, like we said, just to recap, 0 is no pain, 10 is the worst pain imaginable, or that would make you scream and cry. And where are you in between that? And then what's important to ask is what pain can you tolerate? It's some good scripting is, if we, chances are we won't be able to take all the pain away completely. So what's a tolerable pain scale? You said it's a 10 right now. Would 5 be a tolerable pain scale? Or let them tell you, because chances are they didn't get like that overnight, with the chronic pain, of course. And, overnight, the pain's not going to go away. So you just kind of script it like that and say, what is a tolerable pain scale for you? Now, for the individual, like the neurologically impaired or the younger child, that doesn't know how to entertain that abstract of numerical ratings, you may do a Wong-Baker or FACES scale and say, can you point to the pain that you have right now? Or you can say, is it mild, moderate, or severe, which is a little easier to understand. Is it small, medium, or big pain? Is it mild, moderate, or severe pain? Or is there no pain? And a different thing that we don't think about is the patient that is, in a induced coma for whatever reason, or is on sedation with propofol or Versed or whatever, and you're need these people to rate their pain. Or the person with advanced dementia or Alzheimer's, we definitely want to use these pain scales, these nonverbal pain scales for the cognitively impaired. So there's a few different examples. Here's the checklist of nonverbal pain indicators, which is the CNPI. There's a 0 for behavior not seen and 1 for behavior observed. So basically this is objective. So, facial expression, grimacing and crying, 1, or 0. If it's not there, it's a 0. If it's there, like verbalization or vocalization, like they're screaming, you're going to give them the 1. Body movements or restlessness, you're going to give them a 1. Changes in interpersonal interaction, changes in activity patterns or routines, mental status changes. So this is how you would rate that. There's also pain assessment in advanced dementia, PAINAD. 5 criteria point system of 0 for no behavior observed, 1 for mild and 2 for most intense, for a possible score of 10. Again, here's 2, 4, 6, 8, 10. Breathing independently of vocalization, so kind of like moaning or kind of whining, so like tachypnea and increased breathing. Negative vocalization like moaning and whining, or not whining, like screaming. Facial expressions like grimacing. Body language like, writhing around. Consolability, are you able to calm the patient? So again, it's a 0 to 10 scale with each category, each of the 5 categories, with a possible 2 points for each, 0 for nothing, 1 for mild, and 2 for severe. Mechanical event pain assessment is used to establish a reliable, these patients are minimally conscious with these types of sedation. So they do, it's very rapid acting, these propofols and other sedation, or rather sedatives. So sometimes they're just conscious enough to kind of follow simple commands or hear your voice and comprehend. So you want to establish a reliable yes/no system, whether that's a thumbs up or down, head nods or eye blinks. Use of communication boards, pieces of paper, computer or picture boards, so they can write simple words or phrases. Correctly interpreting lip reading by maintaining eye contact, encouraging patient to speak slowly. Okay. There's a pharmacological management of pain, the multimodal approach, and basically this is a very effective method in which the practitioner will prescribe different types of medications, 2 or more classes of analgesics to target different pain mechanisms in the PNS or CNS. So the advantages of this is that it may allow lower doses of each drug with maximum effectiveness. So you don't need the 10 milligrams of morphine. Now you need just 2, because you're getting 2 of morphine, and then you're getting Tylenol and you're getting Toradol. Best to prevent analgesic gaps, meaning like the patient gets the morphine Q 4 to 6 hours or whatever for, this increased pain. However, the patient's asking for his pain meds, but it's not time. So this can kind of the in-between times. Management of persistent and chronic pain. Preemptive analgesia, which accounts for anticipated pain pre, intra, and post-procedure. So if you anticipate your patient being in pain for whatever procedure, lumbar puncture, or even something as simple as a dressing change, things like that, physical therapy, you want to do the preemptive analgesia. Okay, around the clock dosing. This prevents pain, maintains a level of pain control that allows the patient to function and have an acceptable quality of life. For patients reporting pain that lasts 12 hours or more during a 24-hour period. May still need breakthrough pain. These are for the ones that are not controlled by the around-the-clock pain medication. You want to say, get on the phone with the doctor and say, hey doc, I know we got, Q3 hour, 2 milligrams of morphine. However, he's still complaining of pain 8 out of 10. Is there something, can we get some breakthrough pain medication? And of course, the patient-controlled analgesic, or the PCA pump, it allows patients to treat their pain by predetermined doses and time, self-administered method. It empowers the patient, makes them feel like they're a little bit more in control of their pain management. It decreases anxiety, which can exacerbate pain and stress and anxiety. Used for fully cognitive patients who can comprehend complex instructions. So if they're super somnolent and lethargic and they can barely follow simple commands, obviously we don't want to give this patient a PCA pump. So there's 3 classes of analgesic groups: the non-opioid, opioid, and adjuvant analgesics. And we're going to start with the non-opioid. The advantages are they're versatile with multiple agents, routes, and formulations available. Off the top of my head, I'm already thinking Tylenol, naproxen. There's now IV route of Tylenol. There's, what else is there? There's ketorolac or Toradol, which is essentially like a NSAID sort of IV form of the medication. And then, of course, there's PO medications. They're flexible and useful for a wide variety of mild to moderate nociceptive type pain. Foundation of multimodal approach can produce opioid dose-sparing effects. The disadvantages, there's a wide interval, individual differences in response. So obviously, the patient that comes in with the chronic pain, and you go to give them, the doctor prescribed 800 milligrams of Motrin, and they get angry because I do that all the time. That doesn't work for me. So obviously, there's a varying degree of the effect for individuals. Careful considerations of hepatic status, especially for Tylenol, cannot exceed recommended daily dose. Careful NSAID considerations for certain populations, such as older clients and those with cardiovascular and GI and bleeding risk factors. The examples of the non-opioids are acetaminophen. NSAIDs are aspirin, ibuprofen, ketorolac, meloxicam, known as Mobic, naproxen, known as naproxen, and this COX-2 selective NSAIDs like Celebrex. Non-opioid considerations, things to think about. Acetaminophen has a max daily dose of 4,000 milligrams, although experts are recommended a reduced daily dose of 2,500 to 3,000 milligrams daily. Overdose can cause hepatotoxicity and should be used cautiously in persons with already impaired hepatic function, not for inflammation. Often combined with opioids such as hydrocodone. So the like your Norcos and Vicodins and all those Percocets, they're all combination medications that are combined with Tylenol. So it's super important that you let those individuals know in teaching to avoid other Tylenol products while you're taking these types of medications. NSAID should be given something to eat before administering, especially large dose NSAID such as ibuprofen or Motrin 600 milligrams or more. Can cause some GI upset. Chronic use of this can cause ulceration and GI issues. Caution with history of peptic ulcer or cardiovascular disease. Complications include gastric toxicity and ulceration. Opioid analgesics. Advantages. They're the cornerstone of moderate to severe pain. Obviously the patient that is post-op obviously is most likely going to get some sort of IV route, morphine or Dilaudid. Opioid rotation can be initiated with development of tolerance. So rotation of opioids, it's not unheard of, or it's super common to go from, morphine didn't work, so let's go to Dilaudid, or let's go to, fentanyl, whatever it is. MU agonist has no ceiling on analgesia. Higher doses increase analgesia, and only adverse effects limit how high the dose can be. Tolerance develops to side effects with regular daily dose, with exception to constipation, which is the classic complication when it comes to opioid analgesics. Of course, the most important ones are respiratory depression and somnolence. Again, the disadvantages are constipation, excessive sedation, respiratory sedation. Addiction can develop. Close monitoring for sedation and respiratory status indicated during the first 24 hours of opioid therapy. Some opioids can produce metabolites, So obviously after these are metabolized, there's some sort of byproduct that can cause toxicity. Examples of these are morphine, fentanyl, hydromorphone, which is dilaudid, hydrocodone, oxycodone, oxymorphone, and methadone. Complications of opioids, again, are constipation, nausea, vomiting, sedation, respiratory depression. And of course, the last two can be very, can be potentially life-threatening. Lastly, we have the adjuvant analgesics. They're the largest and most diverse analgesic group, and they're the things that you don't think about when we think about pain medication. Like for the diabetic neuropathy, we don't think about gabapentin necessarily being a pain med, but it is just that, but it's considered an adjuvant analgesic. The advantage of these are that, like as we just said, largest and most diverse analgesic group. The side effects are often responsive to a reduction in dose. Tolerance develops to most of the adverse effects. The disadvantages, it can contain the agents that are recommended for treatment of neuropathic pain. Considerable variability among people in their response to agents used to treat chronic neuropathic pain. Most require titration. Most have a max daily dose. And the side effects can be significant. So what are some of these examples? We have anticonvulsants, gabapentin, Lyrica, antidepressants, nortriptyline, Cymbalta, Effexor. We have some, the bupivacaine, lidocaine patches, which are not antidepressants. The baclofen, which is muscle relaxants. Flexeril, again, a muscle relaxant. And then ketamine, which also can be used as a conscious sedation agent. So again, these adjuvants are kind of out of the box analgesics that are used for specific types of pain, and a lot of times they're used in adjunct with other types, non-opioid or opioid, to control pain. One instance is the individual who's post motor vehicle accident, and they come in, the doctor checks out C-spine and everything else, they get sent home, and then they get a script for Motrin and Flexeril, or Motrin and baclofen, because they anticipate the muscle spasms, which will cause pain, and muscle tightness the next day, as well as a generalized inflammatory response and pain. So the Motrin or the Norco is going to handle that. And that's everything for pain, guys. That's everything in a nutshell. Obviously, there's some goodies in your chapter 3 that you want to go over, but that's essentially just the meat and potatoes of this. And again, I'm Professor Garcia, and I just wanted to say good luck on the test, and we'll see you guys soon.